Oh, hi everyone. Welcome to Department of Medicine Grand Rounds. For those of you who don't know me, I'm Adrian. I'm one of the inpatient chief residents here at Montlake. Just a couple of housekeeping things. We have Dr. Hurvitz presenting Grand Rounds today, and I'll do a brief introduction, and then if you can save questions for the end and just enter them in the chat, I will, at the end of her lecture, be reading out questions. So please enter them there. And then prior to her presentation, we have the awarding of some awards. So I'm going to turn things over to Dr. Trish Critic, the interim chair of the Department of Medicine, to present the Bremner Awards.
Adrian, thanks so much, and thanks everyone for letting me join today. I want to first begin by saying thank you to Nisha Bansal, who did a lot of the coordination for this really great event, which is the awarding of the Department of Medicine Bill Bremner Endowed Mentorship Awards. And I think just so everyone's familiar, I'm not sure if everyone's familiar with that fact that we've had these awards since 2015 to really recognize our faculty members who have excelled at being mentors in really any domain, in our scientific and research spaces, in our educational spaces, in our clinical spaces. That the goal of these awards is to recognize what is really essential to academic medicine, which is that we mentor the next generation of outstanding clinicians, teachers, scientists. So it is really an important award for our department, and I'm really thrilled to recognize the two folks who are our most recent recipients. And so one of the joys of receiving these awards is you get a letter that shares all the quotes that were part of the nomination, and I'm going to share some of those as well. But with no further ado, the two recipients of this year's Bill Bremner Mentorship Awards are Dr. Mark Werfel, who is a professor in the Division of Pulmonary Critical Care and Sleep Medicine, my home division, and Dr. Kari Nelson, who is a professor in the Division of General Internal Medicine, working predominantly over at the VA. So I want to say a huge congratulations. I ask people to use their emoji of choice to celebrate Mark and Kari's accomplishment in being awarded these awards. I want to take 1 minute. Oh, see there, here come the emojis. 1 minute to talk first about Dr. Werfel, and these are quotes from his package of nominations. Dr. Werfel taught me to think and act like a scientist. Dr. Werfel showed me that it's okay to follow my passion. I suspect he even encouraged someone to do that. He was a role model as a scientist and a parent who understood where flexibility was needed and how to help me achieve my goals on a fixed promotion timeline. Time and time again, Mark has mentored and protected me in my pursuits, even when they have nothing to do with him. And then finally, Dr. Werfel is a stellar mentor who has had an outsized influence on my career. Mark, I think it speaks to your mentorship of the whole person and the relationships you've had with your mentees. And I wanted to say congratulations personally and ask if you had a couple words you wanted to say.
Thanks, Trish. I accept this award with humility and gratitude. I've had the honor of working with outstanding colleagues, mentees, co-mentors in the department division, and this has really been a team effort. Want to thank my primary mentees, many in my division, including Eric Morrell, Carmen Mikusenich, Lindsay Mabry, Neha Sathe. It's been an honor to be part of their career development, and I couldn't be more proud of what they've accomplished and what they will accomplish. Have to thank my mentor and friend, Tom Martin, who continues his prodigious mentorship as an emeritus professor in our division. Tom was a tireless mentor himself to me in my career development and provided me with a model of what outstanding mentorship looks like. Thank you, Tom. I also want to thank the leadership of our department and division who created an environment with mentorship of physician scientists at the fore. I owe particular thanks to Bill Bremner, the namesake of this award, and Rob Glennie, who supported my early development and research program and mentorship. And I want to thank my family who put up with me through all of this, many trials and tribulations over the past few decades. It's been a journey. So thanks for this special honor.
Thank you very much for those words. And now I want to honor Dr. Nelson. So Kari, let me read a few quotes from your letters. While Dr. Nelson is known as an excellent physician and researcher, I think what really keeps her coming to work every day is a desire to continue to shepherd her flock and to see and share in their success. She furnishes a superb example of an investigator who conducts rigorous and impactful research and maintains balance between her family life and career, demonstrating to junior faculty and trainees that this is possible. Her advocacy for women in academic medicine, combined with her role as a mentor and a role model, has had a lasting impact on junior women faculty. And then finally, Dr. Nelson identifies the distinct strengths of individuals and translates those qualities into specific guidance for each mentee. Again, noting your ability to mentor folks in the whole person, similar theme, as well as your leadership and mentorship of women, which I know is something that's really central to you. So I want to say congratulations and ask if you have a few words.
Thanks, Trish. Yeah, the mentorship award is just such an honor. I feel like the mentoring that we do as part of the department and the division is just really a privilege that we get to do that as part of our jobs. So I just really lean into that feeling of privilege and honor that I got this award. I would really love to thank all my mentees. I just reread the letters that were provided for the committee, and those will be a really special thing that I will keep forever. It just makes your work really important when you hear from junior people that you are having an influence on them. And I have always had amazing mentors, and I can't underscore the importance of mentorship for development of all faculty members. So I just really wanted to say thanks for everyone and all the support that I've received from the division and through the department. Thanks.
Congratulations to both of you. Thank you so much. Thanks to everybody who nominated folks. And my last word is do what Kari said. Save those letters, pull them out on a dark day. They're very inspirational and they speak to how much you bring to our community. So thank you so much. And with that, I'm going to hand it back to Adrian.
Awesome. Thanks, Trish, and congratulations, Dr. Nelson, Dr. Werfel. So without much further ado, I'd like to introduce Dr. Sara Hurvitz, who's a professor of medicine, a medical oncologist, and a clinical research leader here at the University of Washington School of Medicine, where she serves as the division head of the Hematology Oncology Division, as well as at the Fred Hutchinson Cancer Center, where she serves as a senior vice president of the Clinical Research Division. Dr. Hurvitz earned her MD from the University of Southern California, then completed her internship and residency at UCLA, where she was chief resident of internal medicine, and thereafter completed her hematology and oncology fellowship in 2006. As an international expert in breast oncology and a leader in clinical and laboratory-based oncology research, she has extensive experience leading clinical trials in all phases. And Dr. Hurvitz led the breast cancer clinical trials program at UCLA for 17 years, where she was the medical director of the Johnson Comprehensive Cancer Center until 2023, when she accepted a leadership position here at UW in the Fred Hutch. Dr. Hurvitz has won numerous awards, among them the Marnie Levin Memorial Breast Cancer Research Award for 2008 through 2015, and the European Society of Medical Oncology Breast Cancer Award in 2023. She has an active clinical practice that specializes in the treatment of women with breast cancer, and she continues to be involved in designing, implementing, and leading multiple national and international clinical trials testing new targeted therapies. And we're very grateful to you for speaking with us today. Thank you, Dr. Hurvitz.
Thank you so much. Thanks for asking me to be here. And the original title of my talk is very long. And as I was looking at the title and thinking about these tremendously tumultuous times we find ourselves in and the amount of pressure and stress that we're all under right now, I decided to pull back on a heavy-handed scientific talk and focus on a story, how I got to where I am, the path I took, and change the topic to a topic of on the benefits of mentorship and collaboration and the benefits of following one's own path, because I have taken a much more winding path to where I have come. And as I interview fellows for our fellowship program, I laugh to myself often that I never would have been allowed into medical school or residency With the caliber of candidates we have coming through, it is just fascinating to me how accomplished people are so early in their career. And so I remind myself to keep an open mind because sometimes there are people who've taken a curvier path toward a career in medicine who come with gifts and strengths that perhaps would not have developed if they had taken such a straight and narrow path. So there may be a way to include all who are a mixture of candidates who've come this way. These are my disclosures, which primarily relate to funded clinical research from industry partners, as well as my work on DSMBs and in education. So let's talk a little bit about my winding road. I will touch on science along the way as well, but I'm going to try and integrate that with my story. And my family story does begin in terms of my parents at Cal Berkeley in 1950. These two people met in an anthropology class. My father passed my mother a note. She was sitting in front of him in anthropology, and he passed her a note inviting her to coffee. And I think it was like 8 months later that they ended up getting married. And a year later, they gave birth to their first child. My dad was a criminology major. My mother was told by her father that she could go to college if she agreed to only become either a nurse or a teacher. She was on the road to becoming a nurse and dropped out to be a full-time mother. Fast forward, my dad and mom had 4 children in the course of about 9 years, and around 1970, after being in a variety of small homes, moved to this tiny community at the time called Danville. Danville is positioned in the East Bay of Northern California. At the time, there wasn't even a freeway running through it, or it had just completed. It was an area filled with apple orchards and walnut trees and a lot of ranches with cattle. My next door neighbor, actually, her father owned cattle and they had a 200-acre ranch, and I grew up riding horses and doing roundups. It was a very conservative area, but my parents weren't conservative people. They were intellectually curious, and probably could be best defined as progressive at that time. That's the home that I was born and raised in, and we just sold it last year. That's upgraded compared, I think they bought it for $30,000, and I don't have to tell you how much more we were able to sell it for at the time of the sale. But it was a fairly small home for 5 children and 2 parents to grow up in. And this is a picture of us. I'm the one holding the teddy bear in the beginning, and as you can tell by the bell bottoms, this was the early 1970s. With my father in the back and my mother just behind me. And my eldest sister is the one taking the picture, not shown here. So a big Catholic family. And dinner table conversation was really focused around the world news and news that was happening in the moment. It was a very conservative area, as I said, and my siblings went to a public school. And when they showed up one day wearing these black armbands in protest to the Vietnam War, one of the teachers took the time to have my sister walk outside of the room because she was a communist. So the discussions we had at the dinner table that I sat in on at a very young age, but was a part of throughout my early career, really did formulate the way I think about accepting what I'm told at face value, and brought me up to curiously question um, uh, politics and, well, really everything, but made me very curious from a scientific and political standpoint. So growing up, however, in this small community that was not diverse at all, my first love was dance, and I dreamed of being a choreographer, although I loved teaching because I was very bossy, and I liked nursing as well because I like to take care of people. And have always been drawn to art. Shown with the red arrow is Vittorio Russo, my great grandfather, who came over in the late 1800s from Italy, was a sculptor and actually worked on the castings for the lions that were outside the Palace of Fine Arts in San Francisco, that were developed for the 1915 World Exposition. So it's deep in my blood. There's no science in my blood or doctors in my ancestry, but art is deep. And in fact, my brother, shown here in his studio, is an artist and has been in France working as an artist and supporting himself and his 4 children for over 30 years doing that role. So this was my foundation and my comfort zone, and I never thought about science. And then in 8th grade, um, the class of 40 students with whom I'd been since my first grade, the 20 girls became monsters, really, and one could call them mean girls. And I really found myself quite isolated. And in that isolation, I was able somehow to sublimate and hit the books and really gain a lot of comfort by studying areas that I wasn't necessarily initially interested in, and became very interested in math and science and found that I could succeed. Now, through high school, I did enjoy these, but I also enjoyed other things like going to football games and dating. And I wasn't sure that I had what it took to go straight to university. And I certainly didn't have the financial means to ask my parents to put me through, nor the academic prowess to get a full ride scholarship. So I went to a junior college in the area and tested out my skills at science and got some sort of confidence in my ability to do college level science and math, and ultimately ended up at UC Irvine, where I graduated in '93 with a BS in biology and a BA in psychology. Now, I still wasn't convinced I could go to med school. And so instead of taking the MCAT and applying for med school, I became a paralegal. Or legal assistant, really, because I didn't take the test for the paralegal for 2 years. And what that taught me was really valuable, and that is I had no interest in a career in the legal world. So I took the MCAT and surprised myself by doing pretty well on it. I applied to about 15 medical schools, got interviews at 4, and ultimately ended up at USC, University of Southern California. And there, on my very first day of school, Sandy Levine gave a lecture. For those of you who don't know Sandy Levine, she was a candy striper at LA County USC when she was a teen, and almost her whole career was at Big County USC, where she worked as a lymphoma specialist and was one of the leading experts on what was beginning to be observed in the 80s and early 90s, and that is AIDS-related lymphoma. She wrote a lot of the early articles relating to this observation that patients living with AIDS, who are primarily homosexual men, were developing these malignant lymphomas. Now, she didn't lecture about this in her first lecture. What her lecture related to was the immense privilege that we have when we are invited to a relationship with a patient, learning their most intimate secrets and being trusted to take care of them, not just with medicines, but to fully care for them. And she talked about this privilege to be part of this profession and to take on this vocation. And it brought tears to my eyes. She didn't refer to our career in medicine as a career, but as a vocation. And I was sold, and I was so sold by her that in many ways she became a mentor. Somebody many years later asked me why I referred to her as a mentor because I didn't publish research with her. And I explained that mentorship isn't just about working with a physician on a project or an attending on a project, but it's about exhibiting the best qualities of one's profession and being an example. And she was such a stunning example of what it was to be a humanistic care provider, that I just found myself drawn to the field of oncology because of that immense portrait. Later, about a year or so later, she gave lectures on lymphoma and leukemia and told this story, which really sold me on a career in hematology oncology. And it was a story that had just happened. And you may already know this story. I'll be brief, but it's the story of acute promyelocytic leukemia, which is at the time back in the 80s, horribly aggressive, deadly form of leukemia, which was characterized by a translocation between the chromosome 15 and 17, which created a fusion of genes, the PML gene and the retinoic acid receptor gene, which ultimately led to DIC, horrible bleeding out, and patients dying within a week. At the time in the 70s, chemo was used, which kills rapidly dividing cells. But what scientists noticed is the cells were actually halted at a very immature stage of development. And so chemo wasn't addressing those cells and their inability to differentiate and undergo normal apoptosis. And so at the time, she taught us that there are these Chinese investigators in Shanghai who reflected on a very famous analect of Confucius that goes, if you govern the people with laws and control them by punishment, they will avoid crime, but they have no personal sense of shame. If you govern them by means of virtue and control them with propriety, they will gain their own sense of shame and thus correct themselves. And thus, these investigators translated this into a philosophy for managing APL, seeking to educate the cancer cells, coaxing them to differentiate rather than killing them outright. And if they differentiate, then they'll naturally undergo apoptosis. So scientists elsewhere in the US were discovering that there were agents that could trigger differentiation. And one of these agents was retinoic acid, which is a form of vitamin A. But they used a form called 13-cis retinoic acid, which is an isomer of the retinoic acid that was available to the Chinese investigators. They had something called all-trans retinoic acid. And the difference really was just the orientation of the terminal COOH on the molecule. So it was such a very simple distinction between these two molecules. But the Chinese investigators worked with ATRA in the laboratory and showed it looked like it was better than the 13-cis RA. And they treated a 5-year-old patient. So the story was that this 5-year-old girl had already received chemotherapy for APL. It did not work. She was now in the ICU. She was bleeding everywhere, had high fever, was septic, had a rectovaginal fistula, and her parents were ready to put her on hospice. And these investigators approached the parents and said, will you try this form of vitamin A? Will you allow us to treat her with this? It's an oral delivered therapy. And after 1 week, her fever went away, and within 3 weeks, she had a complete remission. At the time of them reporting they wrote a review article around 2000, so 25 years ago. This girl, this 5-year-old, was 26 years old and healthy. So she now, I imagine, is in her 50s, and they went on to publish this series because they then went on and treated another 24 patients, all of whom ultimately had complete remission. So what stunned me about this story was the fact that we could actually target what was wrong with the cancer rather than just killing the cancer, which was distinguished by rapid cell division with chemo, going after what was wrong with the cancer. And this was sort of the beginning of the era of targeted therapy. Now, meanwhile, across town, a man named Dennis Slayman, shown on the left here, was doing work in the late 80s with colleagues such as Axel Ulrich that defined that about 30% of breast cancer was distinguished by amplification of the gene for human epidermal growth factor receptor 2, HER2. And when that amplification was in the tumor cells, that led to overexpression of the protein, which could be picked up by an immunohistochemical stain, as shown here. And patients with this alteration genetically had a 50% shorter survival from stage 2 or 3 breast cancer. So this was sort of an awakening that you could actually distinguish a subclass of breast cancer based on a genetic alteration. And work done by others looking at gene expression profiling, shown in this map here, underscored this work or emphasized this work because we were moving now into an era where you could define cancer, breast cancer subtypes based on the genes that were turned on or off. And when you did this type of subclassification, it was correlated with prognosis and may also highlight genes that you could target with targeted therapy. And so there was this awakening that breast cancer wasn't one disease and an awakening that maybe we could use targeted therapy. And indeed, Slayman and colleagues went on to develop monoclonal antibody trastuzumab, shown in yellow here, which is an antibody that targets the extracellular domain of HER2 and works to actually allow cells to undergo apoptosis and may have some immune stimulatory effects. Now, the mechanism of action of this drug still is under debate at some level, but shown on the right there is the improved overall survival that we see with the advent of HER2-targeted agents, such that the median overall survival for patients diagnosed with HER2-positive metastatic disease at the time of the original approval of trastuzumab in '98 was around 2 years. And by 2013, that survival has gone up to 58 months, almost 5 years. So just underscoring that this discovery has significantly improved the disease course, and actually this is the best disease type now to be diagnosed with breast cancer. And it's shepherded in an era where for patients with HER2 positive disease, we now have 9 FDA approved targeted therapies that go after this that have significantly altered patients' outcomes. In '97, going back to lymphoma, which was my first love, we also saw the approval of rituximab. This was the first monoclonal antibody that was approved for cancer. This antibody targets a protein known as CD20 expressed on B cells or overexpressed on B cells in lymphoma. And this drug was shown to improve outcomes for patients diagnosed with lymphomas. So this was all happening while I was in medical school. Flash forward here. This is me being hooded at my graduation from USC in 1999. The gentleman who is hooding me is actually Richard Hurvitz. My last name was Ulsterland at the time. A week later, I became Hurvitz, and he became my father-in-law. He was a professor at USC and was a cardiothoracic surgeon. And I was well on my way now to UCLA Medical Center as an intern. during my internship and residency, I was drawn to hematology oncology and actually volunteered to do extra service on the bone marrow transplant and solid tumor services because I love the medicine I learned and I love the patients. But I was discouraged because there was only one mentor of mine or one faculty member who was a woman in hemonc, and she didn't have children. And my male colleagues and mentors told me it would be a mistake to go into a fellowship if I had a baby. But being a little bit older as a resident, I ignored them and I had a baby in my second year of residency, and he is now 20, going to be 24 years old. So I just kept on going, and although I doubted whether or not I could go into fellowship as hemonc, I ultimately did go into fellowship, and I joined John Timmerman's lab. John was a lymphoma researcher with a lot of interest in immune therapy. This was before any immune checkpoint inhibitors had been approved. He was mentored by Ron Levy at Stanford, who is a well-known immune therapy cancer immunologist focusing on lymphoma. And John taught me how to be a lab-based researcher. I learned how to inject tail veins of mice and do PCRs and radioimmunoassays and ELISAs. And with his technician, David Betting, who went on to med school later, who very patiently taught me about pipetting, et cetera. I had an incredibly rich experience and was able to begin to work on understanding better the mechanism of action of a monoclonal antibody for cancer, rituximab, and actually got an ASCO Merit Award and was able to publish this work subsequently. And he also taught me how to be a clinical investigator and working uh, with him closely in our phase 1 unit. We studied, we gave some of the first treatment of an immune checkpoint inhibitor, ipilimumab, which was a CTLA-4 targeted monoclonal antibody that wasn't aimed at targeting the cancer cell, but instead targeting the immune cells to turn off the immune silencing that happens that leads to tolerance of the immune system to cancer cells. And that work was subsequently published as well. So now I'm getting ready to, John has offered me a position as a super fellow in my third year to go on and become a fourth year fellow and get a slightly better salary. But here I am, having just delivered my second child in my third year of fellowship, and there's Sean holding his baby sister the day after delivering her. And I was really worried because my husband was in his second residency. He was doing a second residency, and I have 2 kids. And I'm thinking, how can I afford to be a super fellow? Before I show you what happened to me next, I do want to tell you that for those of you listening who are in training and trying to juggle a family and family responsibilities, maybe not children, but other things happening in your life, it is possible and it is okay, and you can do it all. These are my children now. Caitlin's a first year, she's a freshman at UW, studying astronomy and physics, and Sean is applying to medical school, living in LA, and they like each other, and I think they still like us. So this is, again, Dennis Slayman. I showed you him earlier. He was our division head and actually called me into his office when I was grappling with a decision about whether to become a super fellow, because that was the only role open in lymphoma. And he offered me to come on and learn breast cancer and become a breast cancer specialist. And we argued about that opportunity a lot, but in the end, he won and I took the position, and boy, did that open doors for me. But I was able to marry the science that I learned in lymphoma With the science I was learning in breast cancer, and I developed this project here, which was studying the mechanism of action of trastuzumab, and understanding if the immune system plays a role in the activity of trastuzumab, and got a Young Investigator Award for that work, which was evaluating about 1,000 breast cancer patient samples from an adjuvant clinical trial of trastuzumab. And we showed that the Fc gamma receptor genotype actually didn't impact outcome for patients who are trastuzumab treated, indicating that maybe trastuzumab primarily works in its role as an apoptotic inducing agent rather than an immune stimulatory agent. So I'm just going to share two brief projects of work that I've done. Translationally, sort of the focus of my work in breast cancer since that time. And essentially, what my work has been about is marrying the bench with the bedside. So we know that our best ideas often come from the laboratory, generating a hypothesis that we hope to move into the clinical setting. But the clinical setting should also feed back to the laboratory. So every trial that we do, I feel strongly, should generate more information that's not just addressing the main question of the clinical trial, but interrogating new questions that could come up by procuring biosamples or patient-reported outcomes or some other sort of data that can be taken back to our dry or wet laboratories to generate new hypotheses and continue the scientific process going forward. Around this time that I entered my first year as faculty, there was work being done. This is some work that was done by a colleague of mine, Godfrey Konechny at UCLA, looking at whether we could combine two agents that targeted an oncogene, in this case HER2, targeting a monoclonal antibody trastuzumab and a tyrosine kinase inhibitor lapatinib, and seeing if it's synergistic. And preclinically, you can see here in mouse tumor models that in the red line, those treated with both agents had better tumor shrinkage than treating with one or the other. And so this led to a clinical trial, the very first study that I developed as an investigator-initiated trial, where we would enroll 128 patients and who had intact breast tumors. They'd not yet undergone surgery, and these patients were willing to come in and give us a sample of their tumor prior to starting any treatment, would undergo one cycle of targeted therapy so that the chemotherapy isn't clouding our ability to see what's going on in vivo, followed by an extra biopsy after that, then followed by chemotherapy and targeted therapy, and then surgery, at which point we would get more tissue. So this tissue and blood acquisition during this neoadjuvant period is a source of rich biosamples, as you could imagine. So we get both the clinical information of what happens in terms of their tumor shrinkage or response at the time of surgery, but we also get a feedback to our laboratory to look at biomarkers for response or resistance. From a clinical standpoint, we showed that adding lapatinib to trastuzumab actually didn't significantly improve the ability to get a complete response at the time of surgery. We showed that lapatinib, if used alone, was inferior. And we also showed that lapatinib-treated patients had much more in the way of side effects and toxicity. This was echoed by other studies that reported out at a similar time point. In terms of our biomarker work, I was able to collaborate across institutions with Christina Curtis, shown on the top there, who was a really impressive investigator. At the time was somewhat early career, and she was working hard on developing digital spatial proteomic characterization of tumors to understand what was going on in the actual tumor and the tumor microenvironment pre and post therapy. And with her and her colleagues, shown on the bottom there, we engaged in a collaboration where I sent her tissue from this study. And looking at the baseline tumors features, we looked at what features features were noted at baseline that were associated with a higher chance of a pathologic complete response, and showed that those tumors with very high HER2 protein expression had a 12 times greater chance of pathologic complete response, and those with higher level of amplification at the gene level for HER2 also had a higher chance of PCR, and those with a negative hormone receptor status had a slightly higher chance of pass CR. They also went on to look at digital spatial profiling, evaluating 40 tumor and immune markers, and looked at the protein expression changes after a single cycle of the targeted therapy. And they identified tumors that went on to achieve a path CR and showed that these protein changes outperformed the pre-treatment measures in terms of being able to predict path CR. And there was one single marker called CD45 that was identified as a very early predictor of path CR after one cycle of targeted therapy. And so this work is work that is may be able to, and work like this, may be able to identify something like this that then can be prospectively validated in a larger sample size. And as you could imagine, if you could find a marker or two that is identifying patients who are exquisitely sensitive to a targeted therapy, you may be able to actually omit the chemotherapy, which is so toxic, from those patients. The second story I'll tell you about is the story of antibody drug conjugates. These are drugs that are comprised of the monoclonal antibody that targets a tumor antigen, and the antibody is loaded up with chemotherapy or a cytotoxic payload, denoted in the little red spiked things on this picture. And the way it works is the antibody is carrying the chemo, and the chemo is not activated until the antibody is bound to the tumor antigen, at which point, through receptor-mediated endocytosis, the entire thing is internalized, and within the lysosome, the cytotoxic payload is released, enabling tumor cell kill to occur. The first FDA-approved antibody drug conjugate for breast cancer was trastuzumab emtansine, or TDM1. This drug here, I was really lucky to be involved in preclinical work that I'm not showing you here to look at the fact that this, or that identified the fact that this drug works primarily in highly overexpressing HER2 positive breast cancer, and got involved in this phase 2 study showing that this antibody drug conjugate was significantly better in terms of progression-free survival for metastatic HER2 positive breast cancer than giving trastuzumab with chemo. And this was really the first data supporting antibody drug conjugate like this in a comparative trial ever reported for breast cancer. And patients, I should note, getting the antibody drug conjugate didn't even lose their hair because the delivery of chemo was so targeted. And so this went on to a phase 3 trial, which confirmed the benefits of this drug compared to standard of care therapy, and the FDA approval of this agent around 2013. And so we developed a clinical trial to look at this agent in the early stage setting, and again, giving it prior to surgery in the neoadjuvant setting. We compared giving TDM1 with another antibody called pertuzumab versus giving plain standard chemo with trastuzumab and pertuzumab. And again, there was a tissue acquisition biopsy done before and during treatment, and then at the time of surgery, so that we could learn from this. Now, I wrote this study as an investigator-initiated trial, but with the positive results in the metastatic setting for TDM1, the industry sponsor of this IIT came back to us and said they wanted to take this over as a fully sponsored trial, which allowed them to increase the sample size and do a definitive study. And so what we actually showed was somewhat disappointing, and that is that TDM1 led to a pathologic complete response rate of 44%, which was great. That means 44% of patients didn't lose their hair or feel sick, and they had their disease completely disappear by the time of surgery without standard chemo. However, it was inferior to the standard chemo arm, 12% lower path CR. But if you look at their long-term outcome, patients did just as well, regardless of what treatment they received. So the achievement of path CR didn't necessarily change the long-term outcome for these patients. But we had these tumor tissue samples now available to us, and we were able to query them and look for markers of resistance or sensitivity. And actually, through this work, we were able to show that focal HER2 expression, meaning spotty or heterogeneous HER2 expression, or the presence of a tumor PIK3CA mutation, a mutation in the gene for PI3 kinase, identified patients who really did need chemo rather than TDM1. So work like this and work from other groups looking at other markers such as immune markers to predict benefit from chemo versus non-chemo approaches are ongoing and helping us to personalize therapy for our patients. Now, you've probably heard about this other antibody drug conjugate shown on the left side. It's the next generation antibody drug conjugate called TDXD, or trastuzumab deruxtecan. This is loaded up with a different kind of chemo that targets topoisomerase, and it is, again, a trastuzumab payload, antibody. This was evaluated in a phase 3 clinical trial that I was involved in, comparing this ADC to TDM1. And this ADC is much superior to TDM1 in HER2 positive disease in terms of progression-free survival and overall survival, quickly becoming the standard of care. We are interested in this drug because this drug doesn't only work in HER2 positive tumors. It's one antibody drug conjugate that also has what's called a bystander effect. Because the payload is membrane permeable, it's able to leave the cancer cells that have lower expression of HER2 and kill neighboring cells. And so it works in HER2 low breast cancer, which is about 2/3 of all breast cancer is HER2 low. And so we have developed this has been studied in a large phase 3 study and shown to work in HER2 low breast cancer, and it's now available for our patients with non-amplified HER2 low breast cancer. So again, we put together, before I came to the Hutch, I started this investigator-initiated trial that we've since opened here, looking at TDXD and HER2 low high risk early stage breast cancer, again with the tissue acquisition built into it so that we can look at the tissue samples to better understand markers of response or resistance to this agent. And so this is open and ongoing at this center now. And then the last area of interest I have is in diminishing toxicity from therapies that we use as standard of care in oncology. And to get on my soapbox for one moment, I think we're overusing a drug called adriamycin or anthracyclines in breast cancer. I've written fairly extensively on this in my career. I'll just underscore data like these from Heather Greenlee here at Fred Hutch, showing that the use of anthracyclines not only leads to a 1 to 2% chance of cardiomyopathy during treatment with the anthracycline, but it's causing long-term a higher level of cardiomyopathy long-term, as well as a higher chance of problems many years down the road. And we have emerging evidence that the anthracyclines are not beneficial when added to taxane-based therapy. These are just some data in HER2 positive disease. So anyone who's interested in that can reference or look at my references. So now in the closing part of my talk, I'm just going to talk a little bit about mentorship. This is a quote from Steven Spielberg: "The delicate balance of mentoring someone's not creating them in your own image, but giving them the opportunity to create themselves." And I think that's our role here. And I love that my lecture today was given on the day that the Bremner Award was given, because that's what I feel is really my calling now, is not to be at the podium myself, but to give the opportunity and development to other faculty to see their careers soar. So I have done this work at UCLA. I've been involved in mentorship for a number of colleagues who are now successful faculty members in their own right with projects that are ongoing with them, and I don't have time to tell you about them today. But I want to talk to you in the closing about my big move here and sort of what my why I came. And I wasn't looking to come to the Pacific Northwest. I assumed I would be retiring at UCLA. I really enjoyed my job and my role, but Barbara Jung and Tom Lynch were quite convincing and charismatic. And I'm sorry this photo is so blurry, but I wanted a photo that showed how Fred Hutch and UW Medicine are really merged. And I had the opportunity to come into a very unique role to be division head for HemOnc and the senior vice president for clinical research at Fred Hutch. And it was an intriguing role that they described. Now, this role was a bit daunting to consider. And there are enormous shoes to fill of people who've been in these roles. At the time I was being recruited, the Division of Oncology was separate from the Division of Hematology. On the left are Fred Applebaum, Mark Stewart, and then Nancy Davidson, who served as the division heads for oncology, medical oncology before I came, and Jan Abkowitz, the division head of hematology, who is the Bremner awardee in the past, has just been an amazing mentor, and Nancy Davidson, who's has such an incredible legacy as a breast oncologist and leader in medicine. So big shoes to fill. It was daunting to consider this task. And then at the same time, starting on the left upper corner with Don Thomas, Nobel laureate, the father of bone marrow transplant, John Hansen, Fred Applebaum, Ollie Press, and Nancy Davidson, who were in my role as Senior Vice President of the Clinical Research Division at the Hutch prior to me coming. So figuring out how to integrate Heme and Onc and take on a dual role at Fred Hutch and UW continues to be work that I'm trying hard at every day to fill these shoes adequately. So people ask me all the time what surprised me when I came here, and I would say number one is the enormous complexity. And I went to Tom Lynch about a month after being here, and went to Barbara Young around the same time and said, "Do you have a list of those people who report to me?" And this was sort of the response I got. There was no list, and that's because my role was so complicated. There are faculty who report to me who are primary UW and HemOnc and have a joint Fred Hutch CRD appointment. There are those who are primary Fred Hutch CRD and joint at UW. There are those who are primary Fred Hutch in another division and joint in my division at UW, and those who are primary at another site like the VA or Bloodworks Northwest and joint at Fred Hutch. So that's why there was no list. So I set about making an Excel spreadsheet that lives today to help me keep track. These are the people who report to me as of today: 121 physicians and research faculty, 128 APPs, a number of fellows and postdocs, as well as staff, and on the Fred Hutch side, over 40 Fred Hutch faculty. So it's daunting, but I don't do it without support. This is this is the only org chart I'll show you. I don't want to go into it, but just showing the complexity of the role and the rich, amazing people working in the fields of classical hematology, malignant hematology, and solid oncology, and pushing our field forward. I couldn't do it without our section heads, Stephanie Lee, Evan Yu, and David Garcia on top, as well as our amazing administrators. And I don't have time to go through everyone, but Sonia Stella, Mona Dupre, and Laura St. Germain have been just amazing partners in helping me keep it together and move our vision forward. And so what is our vision in the last few slides? Integrating hematology oncology has been a major goal, and with the help of my section heads and administrators, I think we've come a long way. Merging or integrating the UW and Fred Hutch side, as well as managing the clinical research division, which used to be comprised of laboratory-based scientists as well as clinical researchers, and before I came was divided into two different divisions, leaving many people feeling as fractured. And so making sure that we're sensitive to that and navigating those that difference, that change has been a big part of my role. Mentorship and faculty development has been really important, and I continue to do this, but more importantly, I'm trying to encourage our current faculty who are doing a great job at mentorship, and with my section heads are helping to make this a reality for everyone. But I just want to highlight two of people on the breast team, my mentees with recent publications. We just wrote together, Tasha Hunter up on the corner there, and then Will Gwynn on the bottom here. We just published this editorial in Clinical Cancer Research this week. Growth. When I came, I was told that in the next few years I would be expected to hire 8 program heads, 35 or more faculty positions at Fred Hutch, develop a palliative care program for cancer patients, as well as further fill out our cancer genetics program, focus on survivorship, as well as supportive care. And all the while, it's incredibly important to us to expand clinical research capabilities in our community, which we're doing. I actually see patients in our Northwest community practice where we have trials open. I'm so impressed with our faculty there and our staff there, Paul Martin in his ability to lead clinical research there, and Nina Lamble, who leads breast research in the community, has been really great partners in helping us bolster our community participation in our clinical research. Our investigator-initiated trial team is being built up. We have efforts to develop a clinical trial app so that if you're interested in seeing what studies we have available in any disease type, you can just download the app and pull up the disease and stage and see if a trial is available. We're going to be hiring an industry engagement manager to help develop opportunities for our faculty to have more funding for investigator-initiated projects. And we have new initiatives that we're funding for bench to bedside programs. So with that, I will close by just showing you a picture of my happy. This is Henry, our pup. We got him right around the time that I was hired. He's just a little sweetheart. My family in the left corner, my love skiing. I can't wait to explore the Seattle area mountains next year when we bring our ski equipment up here from Tahoe. And I want to thank you all who've been so welcoming and wonderful to me in my first year and a half here. I look forward to meeting more of you and collaborating with you, I hope. Thank you.
Thank you so much, Dr. Hurvitz, for sharing your expertise, your story with us, and vision for the division, Fred Hutch, going forward. We really appreciate that. I want to open it up to the group for questions. If folks don't mind putting questions in the chat, I can read them out. I think one question that I have, just thinking about sort of the uncertain state of funding for research across a variety of domains, is how are you, there's a vagueness to my question, but I guess how are you feeling about the availability, the future of funding for clinical research in your own division?
Yeah, I think I'll just say we are adaptable. We humans are adaptable. we're being asked to adapt at a pace that is really unprecedented. Being an oncologist, have great optimism. I think that's one of the qualifications as a career in oncology is optimism. But I do want to acknowledge that these are incredibly difficult times, and there's going to be a lot of loss and harm with our need to react and pivot away from traditional funding, if this is the way it's going to be, into a way where we're resourcing more of our support from philanthropic and industry partners. And so I think we have to be planning for potentially a very serious change in our future while hoping for some I don't know, reversion back to the way things were.
I love the sentiment that optimism is a prerequisite for a career in oncology. I really appreciate that. I'm gonna give people like 30 more seconds for questions, and then I know it's the hour mark, so we'll, if none are immediately forthcoming, I think we will leave it there. And thank you so much, Dr. Hurvitz. We
Thank
really
you.
appreciate your time, and that was a wonderful presentation. Thank you.
Thank you. Take care.
Have a great afternoon, everyone, and a good weekend. Bye.